Good morning. I'm Aristide Merola, and I'm the director of the Ohio State University Center for Parkinson's Disease and Other Movement Disorders. I would like to welcome you today for our first session of this new virtual education series for people who are affected by Parkinson's disease. If you're here, you either are living with Parkinson yourself or you care about someone who is living for Parkinson. Whatever is the reason for joining us today, we're glad you're here. We hope that this series of webinars will be informative and helpful to you as you manage and flourish with this disease in your daily life. I will serve as a moderator for today's conversation, and along with us, we have a few members from the Ohio State University Wexner Medical Center. We have Dr. Ariane Park, the nurse practitioner Jessica Trulov, the nurse practitioner Alison Daly, actually she is also our genetic counselor, Dr. Changizi, the nurse practitioner Clarice Goas, and the physical therapist Jared Braden. We are also lucky to have our two amazing neurosurgeons, Dr. Brian Dolm and Dr. Vibhor Krishna. So we will learn more about each one of our presenters as we move through the morning. So let's get started with the first question. Which one of the following statements do you think is correct? People with Parkinson's disease are more likely to develop severe complications from COVID-19 infection, or people with Parkinson's disease are no more likely to develop more severe complications from COVID-19 infection than the general population. And now let's see the responses. Let's see how people voted. Wow, so we have a 50-50 approximately. So 35% of voters voted that people with Parkinson are more likely to develop severe complications, and 65% voted that people with Parkinson are no more likely to develop more severe complications. So what's our opinion? There is no direct connection between Parkinson's disease and COVID-19. So we shouldn't be worried about a direct interaction that the virus can have with the disease and with complications. However, of course, people with Parkinson are on average a little bit on the older side compared to the average population. And sometimes there are also other physical challenges. So our recommendation is to be very careful about the potential exposure to COVID. Not because COVID can have an interaction with Parkinson itself, but because there are multiple elements that can represent a challenge. So in general, it's better for people to Parkinson to try and do whatever is possible to avoid the COVID infection. Let's do one more question before we start with our first presentation. So please select the answer that is correct. Let's present our question. The first one is Parkinson's disease is only associated with motor symptoms. So for example, tremor, slowness, or muscle stiffness, or Parkinson's disease can cause both motor and non-motor symptoms. So both tremor, slowness, muscle stiffness, but also non-motor symptoms, for instance, blood pressure dysregulation, cognitive changes, or sleep disorder, or constipation. Very good. And let's see the answers. Oh, excellent. So in this case, we have a 99% vote in what is correct. So Parkinson's disease can not only cause motor symptoms, but can also cause non-motor symptoms. So it can affect multiple aspects of the person's life. And we will learn more about this throughout the presentation we're going to give this morning. So now, without any further delay, let's move to our first excellent speakers, Dr. Park and Jessica Trulov. So I will briefly introduce our speakers today. Dr. Park received her bachelor's degree in cognitive neuroscience from Harvard University, her master's degree in chronic disease epidemiology from Yale, and her medical degree from Ohio State. She had completed her internship and neurology residency at Northwestern Memorial Hospital, and she completed her fellowship in movement disorder at Duke. Dr. Park is currently Vice Chair of Academic Affairs in the Department of Neurology, and she is the co-director of the Ohio State University Center for Parkinson and Other Movement Disorder in the location of Gahanna. Following Dr. Park, We're also glad to welcome our nurse practitioner, Jessica Trulov. Jessica graduated from Miami University in 2006 with a Bachelor of Science in Chemistry. She graduated from The Ohio State University in 2015 with a Master of Science in Nursing and became a certified as an auto-gerontology primary care nurse practitioner. She has been working at The Ohio State University Wexner Medical Center in the Department of Neurology since 2015. She works with both the Cognitive Disorder Division and the Movement Disorder Division. So she really has a view of both of the problems that can affect Parkinson. And today, Jessica will talk to us about the premotor manifestation of Parkinson's disease. Please join me in welcoming Dr. Park and Jessica.
Hello, my name is Ariane Park, and I'm a movement disorder neurologist at The Ohio State University Wexner Medical Center. And today I'm going to be talking about the diagnosis of Parkinson's disease. Parkinson's disease was first described a little more than 200 years ago in 1817 by British physician James Parkinson. He wrote a book called An Essay on the Shaking Palsy, describing what he considered a new disease at the time, based on his observation of 6 people in London, England. What's now considered remarkable about this book was his clear clinical picture of this condition. And this kind of critical clinical analysis of patients is still relevant today, where we continue to rely on accurate clinical descriptions and examination to establish the diagnosis. Where are we today with Parkinson's disease? Well, the graph here on the left illustrates how Parkinson's disease prevalence is very much associated with age. We have age here on the x-axis and prevalence here on the y-axis. About 1 to 2% of people over the age of 60 have Parkinson's, and up to 4% are diagnosed with Parkinson's in the highest age groups. The graph on the right is another visual description, and it shows how Parkinson's disease is projected to continue to increase in the United States by the year 2037 due to increasing life expectancy. So you can see here, it's estimated about 1.6 million people will be diagnosed with Parkinson's disease. And this data was published in partnership with the Parkinson's Foundation just this year in 2020. Now that we've established the prevalence of Parkinson's disease, how do we diagnose this disease? Well, the key takeaway is that Parkinson's disease is a clinical diagnosis. So what this means is that there is not yet a blood test or imaging study that can be used to make a definitive diagnosis of Parkinson's disease in living patients. The diagnosis is based purely on a person's history and physical examination. Every patient with Parkinson's disease is unique. People can have different symptoms at presentation, rate of disease progression can vary, and people respond to medications differently. So it is ideal to be evaluated by a movement disorders neurologist who has the expertise in evaluating this condition and may be able to differentiate Parkinson's disease from other conditions that can look very similar, especially early on in the disease course. In certain situations, physicians may order tests to help make the diagnosis, especially when the clinical picture may be unclear or have overlapping features. And one example of this is the DAT scan. We know that Parkinson's disease is caused when brain cells that make dopamine die. Dopamine is a chemical that coordinates movement. So in 2011, the FDA approved the use of the DAT scan to distinguish Parkinsonian syndromes from other conditions that don't affect the dopamine cells. This test uses a radioactive chemical to light up the dopamine transporter. So you can see in these images that in Parkinson's disease, the DAT scan looks different compared to a normal brain in that there are fewer dopamine cells and therefore less dopamine transporter activity. A smaller area is lit up. DAT scans cannot diagnose Parkinson's disease on its own because other conditions can cause abnormal images, and it does not substitute for a clinical evaluation. Again, Parkinson's disease is a clinical diagnosis, and a normal scan does not necessarily rule out Parkinson's disease. But an abnormal DAT scan can help to confirm a diagnosis, and for this reason, this imaging study is being used increasingly in clinical trials. Not every patient needs a DAT scan. When a patient's history suggests Parkinson's disease and the clinical exam meets diagnostic criteria, there is no need for a DAT scan since it won't change recommendations or treatment. We know that there are many changes in the brain that likely occur years before the diagnosis of Parkinson's disease is made. And I know other subsequent talks will be discussing genetic and environmental factors and also some of the preclinical symptoms that may be seen. There are a number of initiatives underway trying to understand and identify patients in the pre-diagnosis phase of Parkinson's disease. But for now, I will be discussing the clinical symptoms and what we look for when making the diagnosis of Parkinson's disease. The time frame will be from the red circle and beyond. Okay, so the symptoms of Parkinson's disease, the main clinical criteria that we're looking for: slowness of movement, otherwise known as bradykinesia, stiffness or rigidity, resting tremor. This is typically shaking on one side that occurs when not using the arm or leg, and walking or balance problems. You don't have to have all four of these. In fact, many people, but not everyone with Parkinson's disease has a tremor. Really, the criteria that we're looking for is bradykinesia, the slowness of movement, plus either rigidity and or resting tremor. Some people also do have walking and balance problems. The symptoms and their severity are different for every person, and this broad criteria is appropriate given how heterogeneous this disease can be. Some other supportive features include that the symptoms begin on one side, that the symptoms get worse over time, and that they respond to medication. I'm going to go into a little bit more detail about each one of these symptoms. The most characteristic clinical feature of Parkinson's disease is slowness of movement, or bradykinesia. This is initially manifested often as slowness of movement in performing activities of daily living. Early on, it may be just confined to the muscles furthest away from the body. So you can see here with handwriting, with prolonged handwriting, the print can become smaller and smaller. Later on, some patients can have difficulty getting up from a chair and generalized slowing of voluntary movements and reaction times. Can also see loss of spontaneous movements and gesturing. You can see drooling because of impaired swallowing, soft speech, decreased blinking, and lack of facial expression, as seen in this drawing here of a Parkinson's patient, as well as reduced arm swing. The pathophysiology of this slowness of movement is not well understood, but it is the cardinal Parkinson's feature that seems to correlate best with degree of dopamine deficiency. Resting tremor. This is fairly self-explanatory, but resting tremor is the most common and easily recognized symptom of Parkinson's disease. This is a tremor that's present at rest and usually goes away when the limb performs a task. It's usually on one side of the body, typically the hand or arm, but it can involve lips, chin, jaw, and legs. Some patients will actually describe an internal shaking that's not associated with a visible tremor. Early on, this tremor can occur intermittently and vary in intensity. It's not uncommon for the tremor to get worse with stress and anxiety. The occurrence of resting tremor is variable among patients and during the course of disease. Some have reported that up to 70% of patients had resting tremor at disease onset. Rigidity is characterized by increased resistance present throughout the passive movement of a limb. This can be proximal, meaning in the neck or shoulders, or also more distal in the wrist or the ankles. Reinforcing maneuvers, which is asking patients to voluntarily move the contralateral limb, can bring out the rigidity and can be helpful in the clinical examination. Rigidity may be associated with pain, and actually a painful shoulder is one of the most common initial manifestations of Parkinson's disease, although it's commonly misdiagnosed as arthritis, bursitis, or rotator cuff injury. Balance and gait problems. Postural instability refers to loss of postural reflexes, and this is generally something that is seen in the later stages of Parkinson's disease. It usually occurs after the onset of the other clinical features. We can evaluate this with a pull test. Patients are pulled quickly backwards by the shoulders, and we are assessing the degree of retropulsion. So taking more than 2 steps to catch oneself is indicative of an abnormal postural response. Freezing a gait is also known as motor blocks or sudden inability to move. This is one of the most disabling symptoms of Parkinson's disease. Although freezing is a characteristic that can be seen, it does not occur universally in all patients. It may include some start hesitation, which is hesitating when beginning to walk, or a sudden inability to move feet during specific situations like turning or walking through narrow passages. But freezing a gait is a common cause of falls, and there are some strategies that can be used to overcome this. Some patients will try marching to command or stepping over objects, shifting their body weight, walking to music. And this is really where we utilize our physical therapy colleagues to help advise our patients on effective strategies. So I've discussed the motor features of slowness, tremor, stiffness, and walking and balance problems. However, there are a number of non-movement symptoms that can be part of Parkinson's disease. These symptoms are sometimes called the invisible symptoms because you can't see them from the outside, but they can occur during the course of Parkinson's disease or even before diagnosis and can differ in severity from person to person. The next talk will discuss these features, these non-movement features in more detail, as they can really impact the quality of life for people with Parkinson's and their families.
I will take advantage of this time just to answer one of the questions that I received online in the mailbox. So what interventions for urinary incontinence in males? In terms for urinary incontinence, usually we can use some medications, and there are a couple of medications that can work to help preventing urinary incontinence. However, some of them can have some side effects. They can worsen constipation, or they can cause dry mouth or a little bit of confusion. So every time we think about medications for urinary incontinence, we also have to put them on a balance and see whether it makes sense to take an extra medication or whether it makes sense just to have what we call non-pharmacological interventions, which basically means making sure of emptying your bladder before going to bed and going to the bathroom frequently, more frequently than actually you feel the need to make sure that your bladder is empty. There are also some other options that can be used, and sometimes we manage that, sometimes we require the intervention of the urologist, but this is definitely something worthy to discuss with your neurologist. Okay, so whenever you're ready, feel free to chime in. In the meantime, I want to discuss one point from Dr. Park's presentation. She presented the data about the DAT scan. So the DAT scan is an examination that allows to look into the brain to see whether we can have a imaging brain abnormality that is suggestive of Parkinson. We generally don't request this examination in every patient, but we request this only in doubt, in case of doubts. But if there is any concerns about the diagnosis, if we're not sure whether it's Parkinson or essential tremor or dystonic tremor, a DAT scan can be requested and represent the only type of brain imaging that can tell us whether a patient has Parkinson or something else. Good news. Okay, So we give the word to Jessica that she's going to present about premotor manifestation of Parkinson's disease.
Research over the past decade or so has focused on finding a way to reliably identify these premotor symptoms in people who are experiencing prodromal PD. Here is a list of premotor symptoms in Parkinson's disease that have the most research to support them. RBD, which is Rapid Eye Movement Sleep Behavior Disorder, is a sleep disorder characterized by abnormal or disruptive behaviors which occur during rapid eye movement sleep and are often related to dream enactment. For example, talking, laughing, shouting, grabbing, punching, kicking, or thrashing while sleeping. RBD is the premotor symptom with the most research to support its connection to Parkinson's disease as a prodromal symptom. In fact, the evidence of this connection is so strong that groups of individuals with RBD are used in research studies to look for other biomarkers of Parkinson's disease. Studies have shown that 38 to 45% of people with RBD develop PD after an average of 5 years. 76 to 81% eventually develop a neurodegenerative disease after 10 years. 10 independent studies in the past decade have shown strong evidence that RBD predicts neurodegenerative diseases, including Parkinson's disease, dementia with Lewy bodies, and multiple systems atrophy. These are all related neurodegenerative diseases called synucleinopathies. And most cohorts find that patients with RBD are at approximately equal risk for developing both Parkinson's disease and dementia with Lewy bodies. Other non-motor symptoms found in prodromal PD include depression and anxiety, constipation, decreased sense of smell, which has been found to start as early as 22 years before diagnosis, erectile dysfunction, excessive daytime sleepiness, orthostatic hypotension, or drops in blood pressure with positional changes, urinary dysfunction, abnormal color vision, and mild cognitive changes, including attentional issues and executive dysfunction. So why has identifying these premotor symptoms in Parkinson's disease been such a focus of the research community over the past decade? The answer is, the sooner we can reliably identify individuals who are developing Parkinson's disease, the sooner we can possibly intervene to slow or stop the progression. In other words, when we discover a therapy against the neurodegenerative process of Parkinson's disease, and we are able to implement it in the prodromal stage of the disease, then we could stop or slow the disease prior to the onset of motor symptoms. The ultimate goal here is to stop Parkinson's disease before it starts, or to slow the entire course of the disease process. To that end, drugs or therapies that can slow or stop the neurodegenerative process in Parkinson's disease are not yet available. But such disease-modifying therapies are anticipated to be most effective if patients can be diagnosed and treated during this prodromal premotor period. Looking forward, current research is focusing on 1, identifying potential biomarkers, including premotor symptoms that will detect a person at risk of developing PD, and developing neuroprotective and disease-modifying treatments. When both areas of research are better developed, we will have the ability to intervene prior to the onset of disabling symptoms in PD, therefore improving and prolonging quality of life. The most critical gap in the field of PD research right now is to develop neuroprotective therapy, and several extremely promising treatments are in stages of development. Thank you.
Great. So thank you, Dr. Park and Jessica. It was a little bit bumpy start, but the quality of the presentation was great. So hopefully now we're not going to have additional technical problems and the morning will run more smoothly. Our next speaker is Alison Daly. Alison is a board-certified genetic counselor with over 15 years of experience providing genetic counseling for neurological diseases. She currently provides genetic counseling for Parkinson's disease and also for other movement disorders in our department. So before moving with the presentation of Alison, let's just do a quick poll. So I have a question for you, as we did before. The first is Parkinson's disease is never associated with genetic mutations and cannot run in families. Or a small proportion of Parkinson's disease can be caused by genetic mutations and can run in families. However, the vast majority of cases are not associated with genetic abnormalities. Great, great. I see we have a very highly educated group of participants. And the answer is definitely correct. But a small proportion of Parkinson's disease can be caused by genetic mutation and can run in families. However, the vast majority of cases are not genetic in nature. But there are, of course, so many different aspects that we hope to learn from the presentation of Alison. So let's go with this presentation. Is Parkinson's disease in your genes? Exploring the causes of PD.
Hello, my name is Allison Daly. I'm a genetic counselor with the Department of Neurology at Ohio State, and today I'm going to talk about genetics and Parkinson's disease. Today I will review the causes of PD, focusing specifically on the role of genetics in the risk for Parkinson's disease, explore how genetic variants influence this risk, and examine the role of genetic testing in Parkinson's disease. For many years, genetics was thought to play little, if any, role in whether or not someone developed Parkinson's disease. However, we know about 15% of people with Parkinson's have a first-degree relative with the disease. And we know that if someone has a first-degree relative with Parkinson's, so a parent or a sibling, their risk for Parkinson's disease is increased over the general population risk. So these are clues that genetics does play a role in whether or not someone develops Parkinson's disease. And in recent years, more and more has been learned about the genetic risk for the disease. However, before I speak specifically about the genetic risk factors of Parkinson's disease, I wanted to do a general overview of genetics. So in virtually every one of our cells, we have structures called chromosomes. These are long strands of tightly packed genes. We have thousands of genes that we inherited from our parents, and each one of them is an important instruction that guides how our body develops and how it functions. The gene is made of DNA, which you can think of as the language of our genetics. And the DNA is made up of base pairs, or bases, and the bases you can think of as the letters of the language of the DNA. All of our genes you can think of as fitting into a book or instruction manual that guides how our body develops and how it functions. Within that book, you have chapters, which are the chromosomes. Within those chapters, you have the sentences and the paragraphs that contain that important information of our genes. Just like you can have a misspelling or other error in a written sentence, you can have a change or error in the DNA of a gene. We call these changes genetic variants. Sometimes a genetic variant might change the way the gene works, and this can lead to a genetic disease. This is a family tree of a family that has a genetic form of Parkinson's disease. If we look at this tree, we can see that there are multiple people colored in black who have been diagnosed with Parkinson's. There are multiple people across multiple generations, and you can clearly see how the Parkinson's disease is passed from generation to generation. This is a classic example of a genetic disease, and this family has Parkinson's disease as a result of a variant in a gene called alpha-synuclein. Alpha-synuclein was the first gene found to be associated with genetic forms of Parkinson's disease in a few rare number of families. It was found in the mid-90s. Since then, other genes in other families have been discovered as well. We refer to these types of Parkinson's disease that are caused by a single variant in one gene, monogenic Parkinson's disease. And these cases of Parkinson's disease are rare. Only about 5 to 10% of PD cases are monogenic. Most PD is related to multifactorial causes, meaning that it's a combination of genetic factors, environmental factors, and age. So we know that age is the biggest risk factor for Parkinson's disease, and that the risk goes up as age goes up. Some of the environmental factors might be exposure to a pesticide or other chemical, solvents, for instance, or a head injury. So we can use these jars to see how these different factors of environment, genetics, and age may come together to cause Parkinson's disease to develop. So in the bottom left-hand jar, you see the genetic risk that a person may be born with. So you can see there's some amount of genetic risk, but it doesn't fill the jar, and it's not enough to cause Parkinson's by itself. But over time, as you're adding in those other factors of age and environment, the jar can fill up, and you might reach a threshold at the top of the jar that causes Parkinson's disease to develop. Many genes have been identified that may play a role in the risk for Parkinson's disease. This is a graph that shows 90 of these genes that have been found, variants in which are thought to play some role in Parkinson's disease. However, we know that these genes do not account for all of the known genetic risk we know is out there. So there are other genes yet to be found. You can think of all of those variants as fitting into roughly 2 categories. So on the one hand, you have the very rare variants that we don't find very often, but that are associated with high risk of developing Parkinson's disease. So an example of that would be that alpha-synuclein variant causing Parkinson's disease in that family tree I showed earlier. That variant was enough in and of itself to cause Parkinson's disease in those family members. However, what are more common are low-risk variants. So these are variants that individually contribute just a small amount to the overall genetic risk of Parkinson's disease, but they're more common in the population, meaning you can find them in more people. And those variants added together lead to the overall genetic risk for Parkinson's disease. We also know that in some genes, you have some variants in a gene, one variant in a gene that might be lower risk and one variant in a gene that might be higher risk. And so the more we learn, the more complicated we realize the genetics of Parkinson's disease risk is. This increased knowledge of the genetic variants and the genes associated with PD risk has allowed genetic testing to become available to people with Parkinson's. There are several ways in which a person with Parkinson's disease may be able to access genetic testing. The first type of testing is commercial or clinical testing. This is genetic testing usually done in the clinic. It's ordered by your clinician or a genetic counselor and sent to one of these commercial labs. The labs usually offer this testing. You could do individual genes, but more often you're doing panel testing, meaning that multiple genes are being tested at the same time. Generally, the recommendations for who is offered this type of testing include those people with Parkinson's disease that may be more likely to carry a genetic variant associated with their PD. So these are people with a positive family history, people who belong to a high-risk ethnic group, so people of Ashkenazi Jewish background or North African Berber ancestry are more likely to carry a risk variant associated with Parkinson's disease. So they may be more likely to be offered this type of testing. And then finally, people who have young onset Parkinson's disease, onset 50 or younger, would be offered this testing. Testing for the more common but lower risk variants is not widely available, and it's not likely to be very clinically useful or informative at this time, but Genetic testing for PD is expanding, and more people may be offered it in the future and may benefit from it in the near future. Just a quick statement about the risks and limitations to genetic testing in Parkinson's disease. We know by nature that genetic testing for Parkinson's disease is incomplete. We're not testing for every possible genetic risk factor that's out there. So even with a negative genetic test result, a person may still have some genetic risk to Parkinson's disease. Also, we discussed how genetic testing is often done in panels with multiple genes. The number of genes and which genes are included vary from lab to lab, so it's important to know what's included in your test and what is not. Also, penetrance, or the risk associated with a gene, can vary from gene to gene or variant to variant, so it's important to understand the risk associated with your particular test result. Significance of some of the results may be unclear. It's not unusual to get a result of a variant of unknown significance, meaning a variant was found, but whether or not that variant contributes to Parkinson's risk is unclear. You may end up having more questions than answers after you get genetic test results. Genetic testing does not alter medical management for Parkinson's at this time, although this is quickly changing. Finally, the results of any genetic testing can have implications for family members. You can have psychological impact, as well as professional and insurance implications. So it's important to talk about these things with your clinician or a genetic counselor. Another option for genetic testing in PD is that testing done through a direct-to-consumer lab. Direct-to-consumer testing can be done in a person's home. You order a kit from the lab that they send to your home. You use that kit to send a sample, it's usually a salival sample or a swab from inside your mouth, back to the company. And then the lab will provide limited genetic risk information for some health conditions, including Parkinson's disease. Maybe one of the more well-known direct-to-consumer labs is 23andMe, and they provide testing for 2 variants associated with Parkinson's disease. The first one is in the GBA gene. So this is a gene that's been known that variants in this gene cause a recessive disease called Gaucher disease. However, carriers for this disease with one variant in the gene have an increased risk for Parkinson's. 23andMe tests for one variant within this gene, the N370S variant. The next gene is LRRK2, which is another gene associated with Parkinson's risk. And again, 23andMe tests for one variant, the G2019S variant. This is an important limitation to remember with this testing. They only test for these 2 genes, so they don't include any other genes. It's limited to these 2, and it's limited to these 2 specific variants. There are other variants in this gene that are not being tested for. So it's not anywhere near comprehensive genetic testing. Also important to note that neither of these genes have complete penetrance, meaning that not everybody who inherits these variants will develop Parkinson's. In fact, most will not. This is especially important if someone is getting this testing who has not been diagnosed with Parkinson's. It's important to realize that if one of these variants is found, it doesn't mean that that person is destined to develop Parkinson's disease. Finally, there's research genetic testing for Parkinson's disease. So this is simply genetic testing done in the context of a research study. These studies may be, the goal may be to look for new genes associated with PD risk or learn more about the genes that have already been identified. When you participate in a research study, a genetic research study for Parkinson's disease, you may or may not receive individualized results. This should be explained to you in the consent form that you would sign for the study. I wanted to highlight one study aimed at learning more about the genetics of Parkinson's disease, and this is the PD Generation study run by the Parkinson's Foundation. And this study is providing genetic testing for 7 different genes associated with PD, along with genetic counseling free of charge to people with Parkinson's. So if you want to learn more about that, you can go to this website I've listed here. I wanted to wrap up by talking a little bit about why genetic testing in Parkinson's disease is useful and why genetic knowledge in PD is necessary. And you can really think about this on two levels, one, the individual level, and also the larger implications for Parkinson's disease. And on the individual level, genetic testing in the right individual might provide a causal explanation of PD. Again, this is going to be in the minority of people with Parkinson's disease. But if you're able to identify a variant, that helps you clarify genetic risks for family members, and it helps maybe provide prognostic information. We're already learning that some of these genes may present a little bit differently. One may be associated with an increased risk for cognitive symptoms. Another may be a more slowly progressive form of Parkinson's disease. So genetic testing may help us provide some more of that information of what to expect. There are some trials currently ongoing and coming up that are recruiting people that have variants in specific Parkinson's-related genes. So if a variant is found in one of those genes, it might help that person qualify to participate in one of those trials. Finally, as we learn more about genetics, we may be able to tailor future treatment based on genetic information. But on a larger scale, and these are reasons why someone who might be unlikely to benefit individually from genetic testing, why that person might consider participating in a genetic research study, is that knowing about the genetics of a disease such as Parkinson's disease helps us understand the underlying disease better and the underlying biology. So this could lead to us identifying potential targets for treatments for Parkinson's. And those treatments might benefit not only the people with those variants, but also anybody with Parkinson's. Also, genetic research might help us develop better risk assessment tools to identify those people that might be at higher risk for developing Parkinson's disease in their lifetime, or identifying people who may be experiencing early signs of Parkinson's. That would help them get treatment sooner and may help with the recruitment of early stage Parkinson's trials. So if you're interested in learning more about the genetics of Parkinson's or in genetic testing, you can talk to your Parkinson's doctor. You can see a genetic counselor. You can find a genetic counselor on the National Society of Genetic Counselor website, which is nsgc.org. Or you can participate in a research study looking into the genetics of Parkinson's. So I hope that this has been a helpful summary of the genetics of Parkinson's disease. Thank you for your attention, and I hope that you enjoy the sessions for the rest of the day.
Thank you, Allison. That was a wonderful talk that we very much so enjoyed. At this time, I would like to invite our expert panel to join me for the first Q&A session. Currently, our panelists to answer questions will be Dr. Park and Jessica Trulov and Dr. Chang-Easy. Our first question will be, my doctor did a hands-on diagnostic testing. He rated my movements on a scale from 0 to 4. Is this used by all neurologists, and what is the scale called? Dr. Park, are you able to answer that for us?
Yes, I can answer that. So there are a number of scales for Parkinson's disease. I'm assuming the scale that this participant is referring to is the Unified Parkinson's Disease Rating Scale, which is probably the most common one that we use clinically, both in the office and also in a research setting. So that's a scale where we test all kinds of different motor tasks. In particular, looking at tremor, looking at various rapid movements and muscles furthest away from the body, gait, and also rigidity. So we use that scale as an objective way to really measure how people are doing in response to treatment or from visit to visit. So that's my assumption. There's also another scale called the Hoehn-Yahr, which kind of measures disability and where people are in the stage of Parkinson's disease, but the most common one would be that Unified Parkinson's Disease Rating Scale.
Fantastic. Dr. Merola, I am going to send this one to you. Does insurance Medicare typically pay for genetic testing?
Yes, that's a very good point. So typically they do not. And that's why it's so important to be followed in an academic institution, because academic institutions, they have the possibility of involving you into what we call the research projects. That basically is a way to get access to this testing, sometimes at no cost, because the academic institution and the Movement Disorder Society basically covers for that. And I would like to turn this to Dr. Park because she's actually leading a big effort that is called the PD Gene. Dr. Park, can you tell us something more about the PD Gene initiative?
Yeah, no, so I completely agree with Dr. Merola. I think with genetic testing, because of all the things that Allison brought up in her slides, it is really, I think, ideal to have genetic testing done in the setting of a research study, in particular because, you know, there are implications to genetic test results. And when you do it through a study, these are certainly not shared with third parties like insurance companies or employers. And so we're excited to, we're a Parkinson's study group site, and we're excited to be part of the PD generation effort, which is really a national effort to get Parkinson's patients to be able to have free genetic testing. And then we're able to use that data to kind of help further research with the goal of maybe being able to provide more precision medicine, meaning more exact treatments based on a genetic understanding of someone's Parkinson's disease. So because genetic testing right now is not, you know, we know about all these genes, but we don't routinely test in the office because it doesn't necessarily change how we manage patients, and insurance companies won't pay for it. Doing it through a research setting like PD generation is really, I think, the way to go.
Great.
Perfect. Dr. Park, going along with that, one of our questions was, where can I find more information about participating in a research study?
So I would say in general, the Michael J. Fox Foundation has sort of like a Fox trial finder. So you can use that to fill out some information about yourself and your symptoms and see what's nearby you, what you may have the time or energy to participate in. Here at Ohio State, I mean, you can go to our website and also find the trials that I know that we're constantly updating that information, but we certainly run a lot of clinical trials here. At this point, we have trials for almost every stage of the disease. So that is really the best way to keep things moving forward. So I encourage folks to check out our website.
And yes, we are in the process of renewing our website, and there will be also a direct link that you can explore every single trial available in the center. It's something that is coming up real quick, but also please discuss this with each one of us, and we can provide you an overview.
Absolutely. Jessica, this one's for you. Can you talk a little bit about over-the-counter sleep aids for people with Parkinson's disease?
Absolutely. So melatonin is a great option. We use that for sleep and REM sleep behavior disturbances, like the yelling out, hitting, kicking in the sleep. It can be tried for that. We don't like the use of most over-the-counter sleep aids that have antihistamines in it, like Benadryl or Tylenol PM, Advil PM, that those have anticholinergic properties that can cause confusion. So we like to avoid those.
Fantastic, thank you. Dr. Park, there's a couple of questions asking kind of two things that are somewhat related. One, in a quick version, is Parkinsonism different from Parkinson's disease? And the follow-up to that being, can someone have both essential tremor and Parkinson's disease at the same time?
So Parkinsonism is really just an adjective. It really is telling someone that they have some stiffness, slowness, tremor. Parkinson's disease is its own distinct clinical, pathogenic entity. So I would call Parkinsonism more of a descriptor. As far as essential tremor and Parkinson's disease, yeah, you can have both. In fact, there is some data that it's possible that having essential tremor may increase your risk for Parkinson's disease. But I would want to add that Parkinson's patients typically have a resting tremor, but you can have an action tremor too. So there can be some overlap, and remember, they're two different distinct diseases. Essential tremor is different from Parkinson's disease. And so, not everything that shakes outside of a resting tremor is necessarily essential tremor.
Sometimes we have patients that maybe they receive a diagnosis in the past of essential tremor, but this turned out to be Parkinson. What's your opinion about that, Ariane? Was more like a misdiagnosis or something that changed over time?
Yeah, that's where it's pretty tricky. I mean, I think people can have both, and there can be misdiagnoses, and this is where in those instances the DAT scan can be helpful to distinguish between those two diseases, because essential tremor is not really going to affect the dopamine system. So in particular, for those patients who have just a gray zone with the tremor, the DAT scan can really be helpful to distinguish between PD and ET.
Fabulous. Another popular question is, can we talk a little bit about the progression of Parkinson's disease and what is the typical time frame that PD might progress? I'll leave that to you, Dr. Park, sorry.
Okay. That is very variable. I really think that that's the main thing to emphasize, is that everyone progresses at a different rate. And as I mentioned, responds to medications differently. And so we don't really have biomarkers for Parkinson's disease yet to really be able to predict where someone's going to be from point A to point B. And we see the gamut in the clinic. You can see people who've had Parkinson's for a couple decades with minimal symptoms and then more rapid progression. There are some generalizations with, differences when you're diagnosed. With people who are diagnosed when they're younger, they may have a slower progression, but I would say in general, it's important to really emphasize how heterogeneous, this disease is, and we just don't have a great way to predict rate of progression in any one individual right now.
Fabulous. We just have time for a few more questions right now. Are there any research trials that we're aware of for family members who are concerned about developing PD? I'll leave that to Dr. Merola or Dr. Park.
I can take this. So this is a big issue. So the issue of saying Parkinson runs in the family, or maybe I have risk factors for Parkinson. We know that REM behavioral sleep disorder is a risk factor. Or maybe I did the 23andMe and I found that I have a genetic risk factor for Parkinson. Can I do something to prevent this from happening? So the short answer is that not at this time. This is a huge area of development and research. There are very many efforts in this direction, but right now it's premature. So there are at least 2 different gene therapy trials that started for a specific type of genetic abnormalities associated with Parkinson. And within the 2, 3, 4 years window, we will have the results from these gene therapy trials, and we will be able to address this better, but not at this time.
Okay. Fabulous. I think we have time for perhaps one more question. There are a few questions asking about the different causes of PD. Can we talk just a little bit more about the environmental causes, things such as, head injury and pesticides? Are there things such as that or other things that we are aware of that may contribute to Parkinson's, the development of Parkinson's disease? Dr. Chingizi, you want to take that one?
Sure. So there's some risk factors. Do they want to know besides the well water, or can you repeat that last part of the question?
I think the well water and the head injury or anything else would be ideal.
Okay. So there's a variety of things that may lead to an increased risk. They are correct in saying head injury can be one, like repeated trauma. There's the case of Muhammad Ali, who went on to develop Parkinson's disease. There's some increased risk with heavy metal exposure, with drinking well water, which may be due to the heavy metal exposure. There's some slight risk with having dairy products or high milk content. What else? There's also welding. So there may be something, again, with the aerosolized metals that may confer risk. There's the genetic risk that we just talked about in an excellent presentation by our genetic counselor.
Agent Orange.
Yeah, I do have patients with the VA who have been are getting some compensation for and protection because of that exposure. And then, but a lot we don't know. So the fact that it was mentioned there's this genetic predisposition and then some sort of environmental insult, which is likely leading to this, and we really don't know, because we suspect, as may have been mentioned earlier, that the disease is probably brewing for a decade prior to the onset of motor symptoms. And so what may be happening, that makes it very difficult to actually really decide what is a determining factor, because risks for later development of motor symptoms, which would be the bradykinesia, slowness and tremor and rigidity that Dr. Park discussed, you're probably losing sense of smell and constipation, but there are many reasons to have those two presentations. And so that's probably when things are starting from some sort of exposure with a genetic predisposition 10 years prior to the onset. And then things are progressing through the nervous system and later manifesting with motor disease. So, so we know that there's certain things that may damage the cell and lead to, like, for example, inflammation and mitochondrial dysfunction due to this genetic predisposition. And then, but we really still don't know a lot of the other, what is the precipitous cause in some patients that tell them to go on. Oh, and the other one I had mentioned, sorry, is pesticides. That's a big exposure risk as well.
Thank you, Dr. Chinghisi. I think just to summarize also, because we're moving to the break session, I think, yes, pesticides represent a risk factor. Welding or exposures to heavy metals represent the risk factors, Agent Orange. But overall, we still believe that these factors account for a very small portion of Parkinson's. So we have a little small portion due to these factors, another little small portion due to genetics, and for 90% of cases, we just don't know yet. So this is also another reason for which it's important to participate in research for academic institutions to collect samples of DNA and try to understand better. So here we are with this second part of our presentation this morning. And I would like to start this session with another poll question. So the poll question that introduces our next topic is the following. So which of the following statement do you believe is correct? Let's go with the two statements. So the first one is carbidopa-levodopa is the only available medication for Parkinson's disease. Or number two, carbidopa-levodopa is the main medication for Parkinson's disease, but other therapeutic options are also available, and this can be discussed with your treating provider. Let's see. Again, this is an amazing audience, very well instructed, and carbidopa-levodopa is the main medication for Parkinson, but there are other therapeutic options. And so that's what we're going to learn in our next topic. And our next speaker is Dr. Barbara Chinghisi, that we also call Kelly. Dr. Chinghisi holds a bachelor's degree in mathematics from the University of Virginia and neurobiology from the University of Maryland. She earned a medical degree from Duke University and completed a residency at the University of California, Los Angeles. She completed a fellowship at the Albany Medical College, where she went on to direct the deep brain stimulation program. In 2011, she became a co-director of the Center for Neuromodulation at Mount Sinai in New York City. And we were lucky to have her here at The Ohio State University since 2013. Dr. Chinghisi specializes in the treatment of patients with Parkinson's disease and other movement disorder, and she is the director of our educational fellowship program. Dr. Chinghisi today will present when and how to start pharmacological treatments for Parkinson's disease. So please join me in welcoming Dr. Chinghisi for a beautiful presentation.
Hi, everyone. Thank you for that very warm and kind introduction, Dr. Merola. Can you hear me? Okay, so thank you for that kind introduction. As he stated, I'm one of the assistant professors here at Ohio State, and it's my pleasure to talk to you today. I want to welcome all the patients who showed up on a Saturday morning to learn more about their disease and be their own advocate, I think that's fantastic. And there's a huge number of views. So this is really inspiring to see from our patient population, and also how educated you are with this question and answer session. So can we go to the next slide, please? Next slide. Maybe okay. So we heard from Dr. Park, who very nicely talked about Parkinson's disease and the presentation of this, and we briefly talked about causes. I'm just going to repeat this because I think that repetition is always great for learning. So as we know, Parkinson's disease, one of the hallmarks is dopamine deficiency. And what this slide is showing is part of the brain where dopamine is made, called the substantia nigra. There are cells in there which are slowly dying off because we have the disease. And so here is a cross cut. This is the brain, and here's the eyeballs, and this is showing the slide across the patient's head. And when you look at this section and it's blown up to be this picture here, this is a normal slice of brain with a nice black stripe across it. And then this is another slice of brain in a patient with Parkinson's disease. And what we can see here is that this black stripe is much paler in this patient with Parkinson's disease. And in fact, substantia nigra is Latin for black substance. In Parkinson's disease, these cells here are making dopamine, and they're very important in the circuitry that helps your body move. So with this deficit of dopamine in your brain, you develop the symptoms Dr. Park was mentioning earlier, which are rigidity and slowness, tremor, typically at rest. That whole circuit ends up not functioning correctly, and the quality of your movements is impaired. So the reason I'm mentioning this again is because this is a mainstay of treatment for Parkinson's. We need to replace the dopamine in your brain that your brain cannot make by itself because it has this disease. And this slide here is showing two cells in the brain. This is one cell trying to talk to this cell. This is at a microscopic level. And here's all the little dopamine coming out of the cell trying to talk to this one. Here is a slide showing, this picture is showing a lack of dopamine. And so those two cells in part of the brain that controls motor movements, they're having difficult time talking to each other. And that's, again, leading to manifestations of the disease. Next slide, please. So replacing dopamine is the mainstay of treatment. And again, it's looking like the slides are a little bit blurry. So I'm going to say I can either take over my slide presentation, or I want to reassure the people here. I'm going to say pretty clearly what's on my slides, and this is recorded. And we can also, if it's allowed, give you copies of my presentation for you to review later. But replacing dopamine is the mainstay of treatment. So your brain with Parkinson's disease is missing dopamine. We have levodopa, which is a drug that we give you, and that drug is converted to dopamine in the brain. We also have medications that mimic the effects of dopamine. So these things are called dopamine agonists, and my colleague, Ms. Clarice Goes, is going to talk about those in the lecture after mine. These things mimic the effect of dopamine in the brain by acting at those same receptors in the brain that use dopamine in order to function well. Certain drugs block the metabolism of dopamine. So again, the main idea here is to promote dopamine in the brain. If your brain is trying to make dopamine or store what we've given it in drug form that you've taken by pill or other forms, and it's gone to your brain and trying to work, if we can also give you drugs that block the metabolism of that dopamine in your brain, the dopamine stays there longer and it's better able to treat your symptoms of Parkinson's. So you can see a theme here that most of the drugs we have at this time to treat Parkinson's are trying to get dopamine to your brain in this deficiency state so that your brain functions more normally. Think about it like a diabetic who requires insulin. In here, in Parkinson's disease, we need to get this dopamine to your brain so your brain functions more normally as if you didn't have the disease. Can we do the next slide? So why do we have to give you something called levodopa? Well, that's a particular form of this drug that is converted to dopamine. What happens is that not all drugs can cross over the blood-brain barrier to get into your brain to work. And in fact, that's why certain recreational substances, which can affect your thinking and so forth, there's very few of those types of things that are able to penetrate the brain and get in there and to work. Dopamine cannot cross the blood-brain barrier. So we can't just give you plain old dopamine itself. We have to give you levodopa, which is in a pill form. And then that can, when you digest that or take it through the gut or certain inhaled therapies, what happens is it's absorbed through the bloodstream. It swims up to the brain. That levodopa, like in this slide here, crosses out of the bloodstream into the brain, like that picture is showing on the slide, and then your brain can suck it up and use that so that it functions more normally. Next slide, please. So a common question I get in the office is that levodopa is always given with carbidopa, or what is this Sinemet with this very long, complicated name? Why do I have to take this big form, and what are all the ingredients in there? So when you look at your pills, you're gonna see there's this carbidopa levodopa. We often use the trade name because it's so much shorter and easier to pronounce. And when you look at your pills, there's gonna be numbers after them, like 25-100 or 10-100, 25-250. So the first number in that ingredient, that's carbidopa. And the second pill is the amount of levodopa. So the bottle is telling you the milligrams of levodopa that you're getting. The second number is the more important of the two. That's the one that's actually telling you amount of levodopa that's eventually going to be converted to dopamine in your brain. So why do we have this carbidopa component? Well, it turns out that we need the levodopa to not be metabolized in your body, but actually go to the bloodstream and most of it to get to your brain so that the brain itself can use it as opposed to the rest of your body. So that carbidopa, which is the first part of that ingredient, is stopping a chemical enzyme called dopamine decarboxylase, and it's preventing the breakdown of the dopamine in your body, the levodopa in your body, and letting most of that levodopa swim up to your brain through the bloodstream and cross over where it could be used. This is greatly improving both the potency of the drug that you're taking, and it's also stopping side effects, which would happen if the levodopa was converted to dopamine outside your brain. So for example, nausea and vomiting are big side effects from that. So that's why whenever we give this drug, you're always going to see it in a combination pill. And the reason I'm including that slide is I get asked that question all the time in clinic. Next slide, please. So I'm going to talk mainly about levodopa products for my talk, and then we're going to talk about other types of drugs that can be used to treat Parkinson's after me. And that's going to be our nurse practitioner, Ms. Clarice Goaz. So the carbidopa levodopa that I just mentioned, where it always comes in a combination thing, there's lots of different ways to take that drug. The most common one that I would say the majority of folks who are on this drug are taking is Sinemet. And that's carbidopa levodopa immediate release. It's typically a yellow pill that's scored. There's also a controlled release. I'm going to talk about that in a little bit. There's something called Parcopa, which is, again, carbidopa levodopa, but it's dissolving on the tongue. A common misperception is that that acts a little faster because it's dissolving, and that's actually not true. You have to sort of digest it or absorb it just like the pill. It just has the convenience that you don't have to swallow it. We now have a newer drug called Rytary, which is also an extended release form of levodopa. I'm going to talk about that in a few slides. We have something called Stalevo, which is carbidopa levodopa, but in a form that's combined with a third drug called entacapone. And Ms. Clarice Goaz is going to mention entacapone later in this presentation. We do have a new form of therapy, well, relatively new, called Duopa, which is an intestinal infusion system. I'm going to talk about that, but that's a gel of levodopa that's given through a pump into the small intestine. And we have a newer drug called Inbrija, which is an oral inhaler rescue system. So I'm going to mention these before we move on to alternative therapies from levodopa itself. Next slide, please. Okay, so carbidopa levodopa, or the Sinemet IR and CR, and those are pictures across the top, which are probably very familiar to many of you. This is a cheap generic drug, which is converted to dopamine, as I mentioned in previous slides, and it acts fairly quickly, typically within 20 minutes, unless you're in the advanced stages of this disease when you're starting to have problems, such as dose failures or delayed kicking in. But typically, this is expected it kicks in quickly, and it lasts a certain period of time. The issue is that as the disease progresses, your ability to utilize this or store it in cells, or the potency of it, also because of the severity of the disease itself affecting the cells talking to each other. How long this drug lasts is very variable. So in the early stages of this disease, when you're in a honeymoon phase, a typical prescription plan for you guys to come in who start this medication is just 1 tablet 3 times daily, for example, maybe 1 tablet 4 times daily. You feel good, you don't really notice it wearing off, you're on a low dose very infrequently. But then as the disease progresses, it may be that you really have to pay better attention to the timing of the medication, and it's been given at higher doses and more frequent intervals. So when people say, well, how long should this medication last? It depends on the time course of your disease and how your particular brain is metabolizing this and utilizing this drug. So it could be anywhere from, a very few hours to, more like, 4 to 6 hours. What are side effects of this? Well, it can cause fatigue. It can cause lightheadedness, particularly lightheadedness with standing quickly, something called orthostatic hypotension. It can cause nausea and nightmares, and at higher doses, it can cause nightmares or hallucinations and even dyskinesia, which are extra dancing movements. Now, I will say that this may sound a little scary to some of the patients. And again, very often, I have patients who, they read all the side effects because they want to be educated about their disease. And they come to me saying, I don't want to take this drug. I don't like these side effects. And I'll say that these tend to occur. These are all manageable. And that this drug is really one of the best we have because, again, it's replacing the dopamine your own brain can't make. So we can work with you if you have these side effects to combat them or tailor the regimen to avoid these to your specific needs. There's also a controlled release, which is called CR or SR formulation. That's like a slow or a controlled release. And those are those red and purple pills up top. And that's when this levodopa, it's infused with a polymer. Basically what this means is it's kind of a pill that's eroded far more slowly than the classic yellow immediate release, Sinemet. And so it allows kind of a slower kicking in and then a slower kicking off. And we actually had originally hoped that this would help people who have, more motor fluctuations or want some better control of their symptoms because they have more advanced disease. But it actually can be problematic. What can happen is that if you're taking it, because there's this delayed time for it to be, digested or for it to kind of erode through, you can end up having delayed absorption or kicking in. And in fact, and then you can have a lot of it being digested at once. So it can actually be more problematic in later stages of the disease where we have what's called motor fluctuations and lead to more dyskinesia or dose delays. So we tend to use this mainly at night and use Sinemet during the daytime for people with more advanced disease, or we may switch to a medication called Rytary, which is an alternative sustained release formula. I'm going to talk about that in a second. And the other thing I want you guys to know is that the CR formulation can be anywhere from 2/3 to 90% of the potency, meaning the effectiveness of the Sinemet. So again, that's something to kind of just so you can be your own advocate, know that if you're switching or we're on a controlled release formulation and are switching to more of an immediate release, just that change itself will allow more potency of the drug. Next slide, please. So there's this new drug called Rytary, which was approved by the FDA in 2015. Some of you may be taking this. And what it is, there's pictures of the capsules down below. It's a capsule filled with beads that contains 2 forms of levodopa. Again, the same ingredient that was in the prior slide of the Sinemet. But what happens is that because there's these 2 forms, there's an immediate release form of it and then a long-acting one. So by taking this capsule, there's kind of immediate benefit from the levodopa kicking in, and then it tends to last a nice long time in the bloodstream. And the idea of this is for those people who have progressed and have a more advanced form of Parkinson's, where the medications are only lasting a short period of time, this drug is very useful to allow much smoother kicking in and wearing off without the abrupt drop-offs of the medication suddenly wearing off in your brain and you suddenly immediately feeling Parkinsonian again. It's meant to be a longer acting, smoother release, smoother letdown formulation of drug. Now, there can be some issues with it because it's coming, as you can see, in these very specific forms of 95, 145, strength 195. You can't really cut this in half like you can do with the yellow forms of levodopa, where you can sometimes break it and take a little bit of extra or tweak it on your own. So we sometimes have to play around with the dosing a little more carefully using this type of drug. And because it's newer, sometimes it can be quite expensive. But I want to introduce this idea to you for those people who are suffering from motor fluctuations or medications aren't lasting as long as they would like. You could bring this up to your provider and say, is it worth it for me to consider switching to this newer form of long-acting levodopa called Rytary? Because we could calculate what dose would be appropriate for you, and we can also do a patient assistance program for those where the expense would be prohibitive. I will say that typically by using this form of drug, we are able to cut down from, say, I have patients who are taking medicines every 3 hours, waking up in the middle of the night to take medications. And so this can afford them to really cut down the frequency of the dosing and spread out the dosing, maybe get an extra hour of effect. And so it can be very helpful for those patients. Next slide, please. Okay, there's something called the Duopa intestinal infusion system. So this is, again, a type of levodopa system where what happens is we are placing in, like in this cartoon here, and I'm sorry that it's a little bit blurry, but I think it's actually readable. I'm going to explain it. So what's happening is this is a cartoon of a patient's body, and that white thing back there is the stomach. Many of you probably realize that. And there's this tubing that's going in through a surgical procedure with a tube that is permanently sticking out of the stomach. It's very similar to, say, a feeding tube. Some of you may yourselves have that or have a family member with that. And then there's part of this device that's going through the stomach further downstream in the GI tract to hit the small intestine called the jejunum. So this device is surgically implanted. It's a very simple procedure. It's actually done, we have a general surgeon who does this. And then this tubing is attached to this pump, and that's shown in this picture here. And this pump is attached to this cassette. This cassette, you can see it looks like it's kind of got this, liquid form of a medication. This white stuff is liquid levodopa or gel levodopa. And this levodopa is going through this tubing into the stomach every few minutes to give you a constant infusion of levodopa. And you can wear this device 16 hours a day so that you don't have to take medications by mouth during this time. So why would you want to have, this is obviously more invasive than taking medications by mouth or pills. And indications for this would be patients who, again, are having pretty severe motor fluctuations, meaning their medication, their levodopa really it's only lasting short periods of time. And they're having to take medications very frequently, or they're having delayed kicking in of their meds or wearing off of their medications. This thing, because it's constantly infusing, it's kind of like you've got your own system, which is bypassing the mouth and absorption that way. And it's basically going directly into the small intestine for much easier absorption directly through the gut and every few minutes. So it's much more even administration of levodopa to prevent motor fluctuations. This is something that we use. We often use it in patients who may not be candidates for surgeries, brain surgeries for motor fluctuations of Parkinson's. I'm not going to talk about that because that lecture is coming up, and that will be addressed by one of our surgeons who will talk about more advanced surgical therapies for advanced disease. Okay, next slide, please. Inbrija is an inhalation, again, a new drug. So we can see the market coming forward with novel forms of administering the same old drug of levodopa that I mentioned in this slide. So what is this? It's an oral inhaler. This is a picture of the inhaler. And what you do is you place a capsule in here, and then you kind of pop the capsule with this top of the inhaler. You hold it up to your mouth, and then you inhale the levodopa so that it's basically going into your mouth, but without having to swallow a pill. And the advantage to this is being used as a rescue. So it's an alternative form where people can take this and carry this with them for when their standard dose of levodopa is failing and they're getting breakthrough symptoms. Most common side effects of Inbrija are cough, upper respiratory infection, nausea, change in color of the saliva, but these are really uncommon. We typically give about 1 to 2 capsules for a single administration, and we generally allow up to 5 rescue sessions per day. I usually don't give that many. I usually try to tailor the regularly scheduled levodopa administration to try to avoid so many rescues, but it is allowed to be given. And so again, a little expensive, but we can work with insurance companies and so forth to try and allow this. And it's just yet another thing in our arsenal of treating the disease. Next slide, please. So I'm going to use this to transfer the next topic of discussion of drugs to Ms. Clarice Goes. So what I've just talked to you about is levodopa, again, which is taken through the bloodstream, crossing the blood-brain barrier, going into the brain and being converted to dopamine in your brain because there is a dopamine deficiency in Parkinson's disease. But there are other medications that can be used to treat Parkinson's. And then, so a question then is, when do we use those? I will say that levodopa, anyone who has Parkinson's disease is ultimately going to end up on levodopa because it is the gold standard. It is the best thing that we have. If your brain can't make dopamine, the best thing we can do as the disease advances is give you dopamine itself so that you can function better. But there are other milder medications that we can give in earlier stages of the disease that, again, act to help the disorder without having to rely on levodopa itself. And we are using that later on in the course. So again, this slide, unfortunately, a little bit blurry, but I'm going to walk you through it. This is taken from a paper that is meant for physicians and does sort of a decision tree to help neurologists in the field decide what medications to use and when. And here would be this top box. What it says is bradykinesia with slowness and impaired dexterity. And that's when patients are starting to develop slowness with doing rapid movements and so forth. So they become symptomatic motorically from their Parkinson's disease. And if it's substantial, we go down this tree here. If people are less than 60, we tend to use a medication called a dopamine agonist, which is a mimicker of levodopa. And I'm going to let Ms. Goes talk about this. But if they have substantial impairment and they are older than 60, we tend to jump to levodopa itself. And so this path here would be the slide where I'm talking about the previous medications, which are levodopa itself in all its various forms. When you go down this decision tree to this side and you're looking here, these would be patients with milder symptoms. So this box here, for those who can't read it, says mild symptoms. And so then our treatments may be something called MAOIB inhibitors. And these are gentler medications which may work in very early disease. But if these fail, we then jump to this decision tree where we start using stronger medications, which would be things like the dopamine agonists and levodopa. I will add that there are some different or more novel forms of medications, which Ms. Goes will say, which are not included in this decision tree. But this gives you an idea of why certain patients were starting immediately on levodopa, but other patients who may have milder disease or they're younger in age, we will give alternative forms. And that topic, those alternative medications besides levodopa, is the topic of the next talk. And so I'm going to kindly allow my excellent colleague, Ms. Goes, to speak.
Great. So Dr. Changizi, thank you. That was an amazing presentation. And as you mentioned, our next speaker is our nurse practitioner, Clarice Goes. So allow me just to introduce a little bit Clarice. So Clarice graduated with summa cum laude from the Ohio State University in 2008. And her father's diagnosis of Parkinson's disease contributed definitely to her desires to specialize in movement disorder. She worked for 4 years at the Wake Forest in North Carolina, focusing specifically on movement disorders. And she came back home into Ohio in 2019, and she joined us at the Ohio State University last January. Clarice has an experience not only in the treatment of Parkinson, but also in clinical trials, including symptomatic interventions, the brain stimulation, and other advanced systems. So let's go with this poll question. Is it better to wait before starting medications for Parkinson's disease, as they may lose efficacy over time? Or there is no advantage to waiting before starting a therapy for Parkinson's disease, as the medication do not lose efficacy over time? Let's see what the results are. Oh, great. We're going to have a great discussion here. So 74% states that there is no advantage to waiting before starting a therapy, as the medication does not lose efficacy over time. But there is still 26% who believe that levodopa may lose efficacy over time. And Clarice will hopefully clarify this point. And if not, and there are other questions we will discuss later in the Q&A session. Clarice?
Thank you. Thank you for that warm welcome. I will get to it so that we can keep up on our time frame here. I'm going to talk, as Dr. Chingizi said, most patients are on carbidopa-levodopa, or also known as Sinemet, but there are some other drugs. I will say this again to reiterate, if you are only on carbidopa-levodopa, that's not a bad thing and that's not incorrect. But there are some other drugs that we will sometimes use to help your carbidopa-levodopa work a little better, or if you're earlier on in disease, and we're going to talk about those. So there is a class of drugs called dopamine agonists. These are drugs that we often use to make your carbidopa-levodopa work a little better, to make it last a little longer, or we will use it we also use them by themselves earlier on in the disease as well. These drugs you may have been heard called as ropinirole or Requip, pramipexole or Mirapex, rotigotine or Nupro, which is a patch, and two of the newer forms, which is apomorphine, also known as Apokyn or Kenobi. There are side effects when it comes to these drugs. They can sometimes make people sleepy, sometimes so sleepy that they may fall asleep while eating their Cheerios, but this is rather rare, extremely rare, but we do caution folks to be careful. Any drugs that I talk about today can have a side effect of hallucinations. That is a side effect of increasing dopamine to a level that's not ideal for your brain, but this is not a typical side effect. We do sometimes see leg swelling, and one of the bigger things that we watch with these drugs are compulsive behaviors. Typically, this is only at higher doses, but everybody's brain is just a touch different. So we are careful, and we do ask you questions regarding shopping, gambling, eating, things of that nature. So some things that I really want to highlight with these drugs are the two newer drugs, Apokyn and Kenobi. So these are more rescue medications. So if your medication is wearing off, we use these often enough. Apokyn came on the market first. It's a lovely drug, but it is injectable. So it can be difficult for patients without caregivers to give themselves if they are feeling off. Kenobi came second. It is much easier, well, not much easier, but easier to use if you're by yourself. It is a sublingual tab that goes under the tongue. There is a little bit of titration and some interesting things when we're starting this drug, but once we have got it going, it can be very helpful. Next slide, please. And so these are just pictures, if you will. Nupro is a wonderful patch. So it's a patch that you would put on once a day and remove once a day. It comes in a couple of different doses. One of the important things we like to stress about Nupro is just the importance of moving the patch around the body. And this is important for any patch medication that you may take. The reason that we have you do that is so that there is better absorption. The more we move it around, the easier it is for your body to absorb. If you leave it in one spot, the body doesn't absorb it as well. So just to move it around is important. Again, Apokyn, there is the injectable, which is good if you have a caregiver. Usually it's, again, hard to inject yourself and get everything ready to go if you're feeling off. And then the sublingual tablets in their various forms. Next slide, please. Another drug that we often use with carbidopa-levodopa or by itself is amantadine. Amantadine has been around for a long time. Its claim to fame was that it was originally on the market as an antiviral drug for the flu, I believe. But they found out then when Parkinson's patients took this drug that their symptoms improved, and we've been using it ever since. Amantadine is the original drug that was on the market. Again, we don't know exactly how it works, but we know that it increases our dopaminergic responses. Dopamine, of course, being the drug that Dr. Chingizi, or brain chemical that Dr. Chingizi told you that you have less of, that you have Parkinson's. So we try to give you more via drug form. Again, possible side effects, always the same: hallucinations, paranoia, or confusion, rare, especially in the younger population. Nausea, leg discoloration. This comes with a rash. I always tell people, if you see anything that looks like your grandmother's lace, on your legs or your arm. That is the side effect. It is, again, extremely rare, and I wouldn't worry about it. It also goes away if we stop the medication most of the time. Dry mouth, urinary retention, blurred vision, again, not common, but they can be problematic. This drug does dry you out a little bit. So in the past couple of years, we have had 2 drugs come out, 2 extended release forms of amantadine. So they are dosed once daily. One is called Gocovery and one is called Osmolex. Next slide, please. Both of these drugs have once a day dosing. So they are a little bit easier to take. And as you'll see there, again, as most of our once a day extended release doses, they have an extra capsule around them to make them release slowly throughout the day. So these drugs have been pretty helpful for us as well. I also wanted to mention that we tend to use amantadine early on to make your carbidopa-levodopa last longer, but we also use it for dyskinesia. This is essentially our only drug that we have that specifically treats dyskinesia. We can also treat dyskinesia by reducing meds or changing the way in which you take them, or other advanced therapies such as the pump or deep brain stimulation, but this is our medication that can help with that. Next slide, please. Anticholinergics are other drugs that we often use for Parkinson's disease. Often we will use these drugs in Parkinson's patients who have tremor or something called dystonia, which is a fancy term for muscle stiffness that is prolonged. These, again, mechanism of action, how do these drugs work? They antagonize acetylcholine receptors. They help pretty well. Possible side effects, very similar to all of our other medications, confusion, memory issues, or hallucinations, dry mouth, blurry vision, urinary retention. Again, these drugs dry you out. So the biggest consideration I usually tell my patients on these drugs, either cogentin or artane, benztropine, triphenhexadyl, are their longer names, are dry mouth. Usually with all the drying out, patients can find this troublesome. Sometimes their dentists start complaining about it. So it's important to stay hydrated. It's important to stay hydrated in Parkinson's disease. Anyways, I'm always fussing at everyone to drink their water. So still true, but there are also some over-the-mouth biotin products that you can use, or over-the-counter, excuse me. And these help to bring more moisture to your mouth and to just keep things nice and hydrated. You can also suck on hard candies or chew gum. This also helps your mouth to stay nice and hydrated as well. Next slide, please. So Compt Inhibitors, they are also good drugs, and there are a few new ones on the market as well. Dr. Chang-Easy spoke a little bit about entacapone or Comtan, which is also what is in the drug Stalevo. And then there is a new one called opicapone or Ongentries, which is a once-a-day dosing. As those of you who take entacapone know, you typically take it several times a day, often every time you take your carbidopa-levodopa. This new form is only taken once a day, and it's taken at night. So it is new to market. I know we haven't used it a ton, so we're not exactly sure how much insurance is paying for it, but it sounds very promising. Possible side effects include the same things: confusion, hallucination. The one difference with these drugs is that they do turn your urine a funny color. I always warn my patients it's normal, but it can be very off-putting the first time that it happens to you. But it can turn reddish brown or rust colored, also meaning when you have your urine checked, sometimes they have to run a culture instead of the basic panel because it turns things just a hair different than they would be otherwise. Diarrhea, and then sleep attacks as well. One of the important things I wanted to make sure that I mentioned to all of you is that the new form of the Compt inhibitor is taken once daily at night, but you do have to avoid food 1 hour before and 1 hour after taking. So ideally taking it at bedtime because hopefully you're not up in an hour eating, and then lasting all day. Next slide, please. MAOB inhibitors, as Dr. Chang-Easy spoke with you a little bit about, these have been out for a long time. There are newer forms and older forms. These are drugs you may have heard of, such as selegiline, and then there are a couple of different forms of selegiline. One is a pill and one is a disintegrating tablet called Zelstar. Rasagiline or Azilect is something that often you may have taken. Originally, there was some data that we thought that that particular drug slowed down the progression of Parkinson's disease, but follow-up studies have not proven that, at least at this point. And then there is a newer form typically called Xadago that we can also use. Mechanism of action is that it inhibits these amyloid Bs, which increases dopamine in the brain where it needs to be. Possible side effects can be dry mouth or confusion and hallucinations, sometimes a little bit of nausea. The tricky part with the older forms of these drugs, like selegiline, or even Azilect to some effect, is that they can interfere with some foods, although this is not common. I usually tell my patients you really have to have quite a meal of a lot of red wines and stinky aged cheeses and other things that have this particular agent in them that can cause problems. But there are some over-the-counter medications, particularly cold medications, that you need to avoid on these medications. Again, because these can change your blood pressure to dangerous levels. And so that can be a little problematic. According to the latest literature, the newest drug in this category, however, does not come with any of these dietary restrictions, but still maybe some caution with using some of the over-the-counter cold medicines and things of that nature you should talk to your provider about before you would start one of these. Next slide, please. So this is, I believe, my final slide, and this is one of the newest drugs on the market, the Adenosine A2a Antagonists. So Noriaz is the name you have probably heard it called as. We don't know why it works exactly, but it antagonizes the A2a receptors. And side effects can include insomnia, again, hallucinations or dizziness. Its claim to fame, using with your carbidopa, levodopa, or other drugs, is that it's a once a day. You don't have to take it at night or in the morning as some of the other drugs. It can be either time. There's no titration. There are 2 dosages of these. So not a drug we have used a lot of yet due to it being so new to market, but it definitely is out there and available for use. Next slide. And that concludes my presentation, and I believe we will be going over to the question and answer session at this time.
Great. Thank you, Clarice. So I would like to lead a little bit the next session of Q&A. And I realized looking at the Q&A, so first I want to make a statement. So there are a lot of great questions, and all of these questions will be answered in a written form, and this will be available. So in second point, the slides will be available on the website. We will make sure they're not blurred. This is the first time we do this event, so please cut us some slack, but we'll do our best to improve technically. But there are 2 questions in particular that I realized we didn't address well, and you're asking for a clear answer. And so let me address them to Dr. Cengizi. The first one is this. Is there any advantage in delaying the starting of a treatment for Parkinson? If I start levodopa later, can I save something? Is this going to last longer? Or is there no advantage in delaying the start of the medications? Dr. Cengizi.
Yeah, so let me answer that. It's a complicated question, and I will try to not make it complicated. So I agree with Dr. Merola. He had that question at the beginning of the presentation talking about whether or not to start therapy. I would say it is advantageous to start treatment that is effective for improving your motor functioning as soon as possible. Which one of those medications can vary, again, based on your age and the severity of your disease, because milder medications may be sufficient at getting you up and operational. The reason I say it's important to start medication earlier is because exercise has been shown to be neuroprotective. And in a disease where we don't have a cure, it is absolutely imperative for us to make use of any other types of treatments that will slow down disease progression. The more active you are physically, the slower your disease will progress, both because of actual impact on the dopaminergic systems of the disease itself, and also because of general physical health. Cardiovascularly, you will be better. You will have better blood flow to your brain. You will be in general better medical shape if you are staying active. So living with slowness and rigidity and tremor so that you can't walk or you can't jog or you can't do a stationary bike is not helpful. You need to have treatments so that you can start to do those activities.
Thank you, Dr. Changizi. I want to
Yeah,
make
sorry.
sure that we are very, very clear about this point. So let me get a little bit more insightful. So if this is the case, why the medications for Parkinson after 5 or 7 years, patients start developing side effects? Is because it's a side effect of the medication, or is because something is changing in the brain? Why it happens?
Yeah, so what these questions may be referring to is that over time, motor fluctuations develop, and we alluded to this in the presentation. And that is where, because the disease is progressing, the duration of time the medications last and the dose that is required, you need more frequent medication at higher doses. And that's because the disease is progressing. You have less dopamine your brain is making yourself, and your ability to store it and the brain's reception of that dopamine is impaired. So there is a misunderstanding that the medications at some point are failing to work because this phenomenon of requiring higher doses and more frequent doses of levodopa is happening. And in fact, no, the medications are working. You just may need them at higher doses. And that phenomenon is not accelerated by taking the medications earlier. That phenomenon is happening, we now think, because the disease is progressing. So you're not damaging your brain by taking the medications for Parkinson's. You're actually helping your brain because you're allowing yourself to be more active, and you're doing beneficial effects by this exercise, and also mimicking a physiologic normal state with the medications. So you are not advancing the disease by taking the medication.
Excellent. That's
Would you
very,
like to
very clear.
elaborate? If I'm
Absolutely.
missing
I think this was covered, but it's a very controversial point. But we definitely know this. We know this because studies done in Africa, where there were a population of patients that just took the medication very late, after 10 years since the onset of Parkinson, because doctors going to Africa gave it to them. The medication lasted only a couple of years, while medication started earlier, they last longer. Is the brain that is changing? And that's the reason why the medication loses, to a certain extent, effect, not because the medication itself causes tolerance or habituation. The second question, I want to be very, very clear, because again, this is a source of misunderstanding. So Dr. Changizi, please explain what's the difference between Parkinson and Parkinsonism. Why there is so much confusion? What do we mean with Parkinsonism?
Yeah, and no, that's great. Thank you, Dr. Merola. And it's a conversation we have pretty much when people are first diagnosed in the office. So Parkinsonism is, in neurology, we like to localize where is the problem. And when a patient comes in and they have this combination of symptoms, slowness, they have to have slowness, they have a tremor, typically at rest, and they have stiffness and often some balance issues. When they have at least two of those things, one of them being slowness, we know that what they are suffering from is Parkinsonism. That is that constellation of symptoms all running together. And the reason that's important when we say you have Parkinsonism, we see all of these things running together, is we are diagnosing what the problem is. You don't have weakness, you don't have sensory loss, you have Parkinsonism, you have impairment of the quality of your motion. The next step that we do, once we've determined you have Parkinsonism as a descriptor of what is ailing you, is we say, well, where is that coming from? And that always comes from the brain. And then we decide what is the disease that is causing the Parkinsonism. The most common is Parkinson's disease, which is what Dr. Park talked about at length. Parkinson's disease is a very specific disease entity with very specific changes seen under the microscope when we look at the brain, with a very specific disease course and treatment options. There are other things that mimic Parkinson's disease, which have different courses and different responses to medication, but they have a similar presentation physically on neurological exam. Those folks have Parkinsonism, but the cause of their Parkinsonism is not the classic Parkinson's disease, which is true in the vast majority of cases. They may have another disorder, such as dementia with Lewy bodies, multiple system atrophy, or other things.
Great. So just one question before the break, and this is a question I want to address Jared, our physical therapist. So this is a very good question. What are some of the hallmarks that a person who may come in for treatment of shoulder pain to physical therapy that may differentiate between bursitis, rotator cuff, or adhesive capsulitis? Oh, this is an insightful question. So,
Yes.
Jared, please tell us something about shoulder pain. So many.
I really love the overarching theme, though, first, is that we need to manage orthopedic conditions in the Parkinson patient in order to promote movement. And Dr. Changizi highlighted that. How do we keep moving? We have to manage joint pain, just like anything else. So if you come to a physical therapy session, you will probably have seen your primary care physician, and now you have shoulder pain. There are some special tests. There are some hallmark signs of adhesive capsulitis. We'll lose range of motion in a certain direction that will match that. Rotator cuff injuries and bursitis are going to present with painful arcs and weakness in certain directions. And so there's plenty of medical tests that can help arrive us to that. But I think the overarching theme is, first, we need to be diagnosed. Second, we need to treat every orthopedic condition that prevents us from movement. So movement is sustained over time.
So, Jared, if I understand, sometimes patients have people with Parkinson, they have pain in their shoulder.
Sure.
Sometimes this pain is due to Parkinson, sometimes it's due to orthopedic problems, sometimes it's due to both. What's the way in which you recommend to progress?
To progress? Well, there is a postural component with Parkinson's that leads to shoulder pain. So first, there is some special considerations to treating orthopedic conditions with Parkinson's. So we would have to address the posture first because it's going to limit how we use our shoulder. And then we need to first decrease pain in an acute stage, and then we can progress from there with a slow addition of resistance and range of motion exercises.
That's great. That's why physical therapy is so critical. Very, very critical, both to prevent the development of complications, to improve. We can give as many pills as we want, but if we don't retrain the motor system in functioning the normal way, this is going to be only half of the job.
Yes.
And let's move forward with our next presentation. So our next speaker is Jared Braden. Jared is an alumni of Ohio University, where he earned his Bachelor of Science in 2007 and a doctor in physical therapy in 2010. So Jared is a certified clinician in the Lee-Silverman voice treatment, as well as Parkinson wellness recovery. Jared has worked in outpatient neurological physical therapy since 2011, with the last 5 years at the Ohio State outpatient rehabilitation. He serves as a Parkinson team coordinator for our outpatient rehabilitation team. And today he will talk about physical therapy and other non-pharmacological interventions. Why and how? So please welcome Jared, and looking forward to his presentation.
Thank you so much for having me and the warm welcome, and thanks for your time on a Saturday morning. I am covering the physical therapy portion and other non-pharmacological interventions. So let's start with the why as we get into it. There's some objectives that we'll cover: neuroplastic benefits of exercise. We'll understand what are the evidence-based recommendations of what we know already about exercise with Parkinson's disease. We'll learn the benefits of high-intensity exercise that's properly monitored. And we'll learn some objective measures that we use in physical therapy to monitor functional decline or functional improvement. And we'll understand the need for ongoing community-based exercise for patients with Parkinson's disease. First things first, everyone should exercise. There are a multitude of benefits of exercise. This is not unique just because you have Parkinson's disease, but there are some additional benefits of exercise when you do have Parkinson's disease. Neuroplasticity is one, and especially early on in the disease process. The brain is plastic, the brain can change. And so in certain ways, we can promote brain change with exercise. And this process aids in the recovery of function following neurologic injury, including Parkinson's disease. So there's strong evidence that now exists to indicate brain plasticity and postural changes in patients with Parkinson's disease. And so the training has to be properly dosed, monitored correctly, and we'll see changes on a chemical level, tissue level, and the functional changes that we're looking for: walking better, climbing stairs better. And so how do we optimize it? Research is telling us that we need to engage the sensory system as much as possible, and more often the intact sensory systems: vision, auditory, ones that are less affected by Parkinson's disease. Because we'll come to find out that Parkinson's is not just a motor system disorder, it's also how we interpret our body in space disorder. We need to challenge the cognitive system. We have to think about exercise. We have to think about the way we move. And of course, we have to challenge the motor system, and that's the actual action of moving. Dosage has to be correct. It has to be intensive. It should be difficult but doable. It has to be highly repeated. The brain learns through repetition. A painter, unless you're a savant, they practice painting. And so turning to sit in a chair is going to be our painting. We're going to learn a new task. It needs attention. We have to pay attention. It has to be a motivating environment. And we have to have consistency in the feedback we get, as well as the repetition of the task. So here's what we know about exercise in Parkinson's disease. Not necessarily groundbreaking. Resistance training improves strength. If we're weak, we have to have resistance training. Parkinson's patients are not necessarily always weak. It's more of a movement system disorder. So there's a different way of addressing it. We work on aerobic exercise that improves our cardiorespiratory fitness. Intensive exercise may have beneficial effects on functional measures, including our walking performance, our balance performance, improved turning, getting up out of chairs, getting off that low couch during the break. And then we'll see better UPDRS scores, in which your neurologist is testing, and quality of life is improved. However, inconsistencies in dosage and the interventions that are applied in exercise and physical therapy kind of limit our current conclusion on what's the best thing we can do. No studies have ever found a deterioration in outcomes. You don't get worse by moving. You don't get worse by exercise. It's an important concept. Intensive exercise is feasible and safe if it's properly monitored in people with Parkinson's disease. In rehabilitation programs, they should begin as soon as possible. In programming, it should be comprehensive. It needs to include aerobic exercise, strength training, and other intensive exercise interventions that are focused on the size of your movement, the quality of your movement, and the effort of your movement. Not all exercise is created equal for Parkinson's disease. There are some things that are better than others. And programs should last several weeks. They should be intensive and they should be repeated over time. We're not curing Parkinson's disease with exercise. We are managing Parkinson's disease. And so if exercise isn't necessarily built into your life early on, we have to learn to move. And I'd like to think about, if we're not moving, how do we get moving? If we are moving, how do we move more frequently? And if we're moving frequently, how do we move more intensively? So what we're still learning about exercise in Parkinson's, it's what's the effective dosage, which specific exercise prescription is the best, and what's the most effective means of forcing exercise. There's a developing body of evidence around the importance of forced aerobic exercise training. It's the speed of our pedaling, it's the speed of our treadmill, not necessarily the heart rate, not necessarily the typical measures, but the forced movement seems to be a little bit more beneficial to getting global improvements in motor function. So Dr. Park talked to you about the cardinal signs of Parkinson's disease. I just want to reiterate what we do in physical therapy and what we do in exercise to address these. Resting tremor, unfortunately, exercise and physical therapy doesn't have much of a response to. And sometimes after you exercise intensively, you might notice your tremor is up for 1 to 2 hours afterwards. It will go down again, but unfortunately, I don't have much of an intervention there. Bradykinesia, these are their slow, small movements, and we treat that with high effort, big movements. That's relearning a new way of moving with typically sometimes when you start out, one side moves a little bit less, a little bit slower. And so we focus on speed and amplitude of movement and exercise there. Rigidity, that's that tightness and co-contraction. And we'll use rhythmic stretching programs in order to maintain spinal mobility over time. Postural instability, that's those abnormal postural reflexes. And we'll work on balance training challenging the system when you're stepping, mainly initiating a step and holding balance. And then the impaired kinesthesia, that's impaired way of interpreting your body in space. And so we need to capitalize on sensory systems. So if you work on exercise with me, it's very loud, it's very motivating, it's trying to capitalize on as many sensory systems of your body that I can, with voice, with vision, and you also contributing as well. And then developing research is looking at our additional sensory system dysfunction with Parkinson's disease that Dr. Changizi alluded to. So this is what we move. This is how we move. There are specific exercises that will help. And so we look at bradykinesia, we look at rigidity. We need to strengthen your postural extension. So let's all sit tall and feel that. Those are your extensors, and we can all sit tall together because it's not a physical therapy talk unless I'm nagging a little bit. And so we treat those with postural extension. We need to keep the spine mobile. We need to relax the co-contraction the best we can with conservative treatments. And so we treat postural instability with our balance reaction training, our functional movements. And then our kinesthesia, again, we need to capitalize on as many sensory systems as we can. One study I want to highlight for everyone is that the Parkinson's Outcome Project, was done by the National Parkinson's Disease, or National Parkinson's Foundation, clinical study of 12,000 participants in 5 countries. We need to reach 2.5 hours of exercise. That's kind of a major conclusion. We need to find that in a week that we can commit to 2.5 hours of exercise, because it's lowering the degree of mobility impairments, it's reducing the burden on our caregivers, and it's reduced impairments in our activities of daily living, dressing, bathing, moving around the house, those sorts of things. It is important that we try to commit and we try to find a place in our day that's committed to exercise. Animal studies, they're indicating enormous capacity of the PD brain to reshape itself with self-produced activity. You have to be engaged, we have to move, and these are the interventions that seem to be most helpful. Their action observation training will explain treadmill and aerobic exercise seem to be more helpful. And then high intensity exercise and rhythmic music are also contribute to kind of better outcomes in regards to what we choose to do as exercise. Action observation training, it's very simple. You are observing somebody and doing the movement with visual and auditory feedback. And so a lot of what we're doing is forcing the size of the movement. It's a specific movement, and we're forcing the effort of movement above what you would self-select to move. That's the important part. We move more intensively. Then we can add cognitive tasks. Then we can give you feedback on the awareness of your movement. These seem to be more helpful than sitting on a machine and just straightening and bending your knee. It engages the cognitive system. We're treating the brain here, so we need to be involved. Aerobic exercise, this is a big part. And there was a question in the chat, what can I do early on? This is one thing you can do early on. You can start an aerobic exercise program 3 days a week. And this would be a very beneficial part of your management plan with Parkinson's, according to the literature. And we're noticing functional brain changes correlated with aerobic fitness, slowing disease progression in animal research. It enhances neuroplasticity. We maintain mobility and quality of life measures for longer. Breathing's improved. Obviously, cardiorespiratory fitness with decreased fatigue. Those are all benefits. This would be a good place to start. And we want to do it in a forced effort manner. We want to push how fast you're going. We don't need to put a bunch of resistance on a recumbent bike in order to achieve this. We actually need to get your RPMs up. We need to get you pedaling faster with somebody encouraging you to do that, or pacing with a metronome, or putting a fast-paced song on so that we can utilize as many sensory systems as possible while we exercise. High-intensity exercise is very buzzy right now. That's like where you do short bouts of high intensity followed by doing something slower. So speed the treadmill up quickly, and then you walk for 2 minutes, speed it up quickly, walk for 2 minutes. They are showing that there acutely increases substantia nigra and prefrontal brain activity in people with Parkinson's disease. If it's repeated frequently over time, it may serve as a potential mechanism underlying exercise-induced Parkinson's disease-specific clinical benefits. It's exercise, it's aerobic exercise. That's a good place to start. In rhythmic music and dancing, activates neurons serving motor control and increased blood flow in regions like the hippocampus, frontal, temporal, and parietal cortices. Their pacing of song, pacing of dance, these seem to provide some additional benefits to movement when we are hearing, when we are seeing, when we are pacing ourselves. So research says that dance can help with walking, balance, postural control, general confidence and mobility, which is important. Movement initiation, if there's some freezing, pacing helps to initiate movement. And then we need to challenge the cognitive system with the motor system. Once we train walking, we need to train walking with a small cognitive task so that we can set shift. We can think about walking, we can think about talking, we can think about walking, and kind of go back and forth. And then a big part of physical therapy is that we need to work on function. When you have a specific task that you want to get better at, if it is transitioning a curb to step up, then we need to really repetitively work on that task. And we need to work on it big and effortfully and figure out a new way of moving so that we can work specifically on the tasks. And that's the common carryover. In physical therapy, let's work on what specifically is difficult, and then let's incorporate a community exercise program. Let's get a home exercise program. Let's create a culture of movement and exercise. And when we need to work on a specific task, let's see each other so we can work on a specific task. Exercise is prevention. It's not just about getting better at something, but it's also maintaining. It's reducing these secondary complications that can exist from not being able to move as well as you want to. So we look at some other non-pharmacological interventions, speech therapy, occupational therapy. There is pelvic floor physical therapy focused on incontinence issues. And these are in psychology, social work, nutrition and diet, sleep health. These are all very important other topics that are going to come up in our future educational symposiums. So stay tuned through the year as these kind of topics are delved into a little bit more by more professionals than I am. So we need to bridge the gap. Formal PT, let's work on specific function, but let's also start to combine how we can move more frequently to achieve our 2.5 hours of exercise a week. Let's set that goal. These slides are just going to run, so you don't really need to change it. But these are some ideas that we have at OSU for just community-based exercise. So we do forced aerobics. We talked about how that stimulates the system if we are filing. Our exercise physiologist will coach you through pedaling faster, walking faster, picking the correct ergometer that helps. We do a moving with purpose class where we focus on amplitude of movement, postural awareness, the big, fast, effortful movements. And we varying assistance levels in intermediate or advanced based on just our current level of mobility. We focus on voice and shout. It's amplitude of voice. It's how loud we talk. It's how effortfully we talk. Voice production is a motor movement. And so we focus on very similar things that we do in the amplitude of movement. Let's go for a walk outside. We can learn to use poles to help us with stability. If knee pain, back pain is an issue, they help unload some joints. It's nice to be immersed in nature. It's a task that you can figure out to do with a loved one. Connectiveness is important as well. You can dance with Chloe. Columbus Dance for Parkinson's Disease is doing virtual classes. They're focused on big movement, that rhythmical, music-based sensory system stimulation that we talked about earlier. And we always thank the National Parkinson's Foundation. Our programming outside of those for community-based is supported by a community grant to the Parkinson's Foundation. These are our locations for outpatient rehabilitation. We have Parkinson's disease specialized therapists in all locations. it is important to see a physical therapist who knows about your condition, who's familiar with your condition. Thank you so much for your time, and I really appreciate your attention. Thank you.
Great. Thank you, Jared. I think that was an excellent presentation, and I want to make a little deviation from the program, and I would like to ask you one question. So we keep most of the questions later, but please address just the question before moving forward. So one of our goal today is to take a complex terminology and make it simple and understandable in plain English. And a question that I found in the Q&A is the following. The question is, what is exactly brain plasticity? So we use this fancy word, but what does this mean? Jared, can you please explain with simple word what brain plasticity is and why exercise can help brain plasticity?
Yeah. Brain plasticity has been going on since the day you were born. It is the way we are learning new tasks. It's the way that we interpret our experiences from the world, and we learn a different way of whatever it is, experiencing, moving. It's a variety of different things. It's the hallmark of how we grow and advance. And so aerobic exercise basically increased blood flow. Increased blood flow to the brain promotes the transmission of different chemicals that help promote healing, help promote growth, provide nutrients. And so if we can utilize experience, we can utilize a bunch of different sensory inputs, a bunch of different experiences in a very supportive environment, which is also important, is that the environment should promote brain growth. And so a healthy, motivating environment, it helps us learn better. And that goes for learning a million different things. But for motor movements, there are some specific just avenues of helping to learn new things. Now that happens more in the early stages of Parkinson's disease, and we have to compensate for things later on when the brain is less likely to learn a new task. We add different kind of compensatory aids, things to help facilitate movement over time. But especially early on in the disease, let's optimize.
Very good. So allow me to say this just to make this even more clear. So the neurons interact to each other, but this interaction doesn't happen just because the neurons are there. It acts because we do something. So if I start playing a piano, I develop some skills because my neurons start interacting with them. Parkinson is a disease that attacks neurons. So these interactions tend to fade away. But if we exercise, we can fight this. And so these neurons can start sprouting again and keep on interacting. And we can fight this, and the earlier we start fighting this, the better. Because when we have a lot of neurons that can act, we can train these neurons to interact with them. Jared, do you think this is a fair explanation of what brain plasticity is?
Yes, and you are the expert, and I appreciate that.
That's not true. So I don't want to waste time, and we also have the most interesting topic of the day. We kept it for the end. So we are going to introduce our neurosurgeon, Dr. Brian Dolm and Dr. Vibhor Krishna. So our final presentation will focus on advanced therapeutic options for Parkinson's disease. But before moving into this presentation, just one very quick poll question. So let's go with the poll question. So what about deep brain stimulation and other advanced therapeutic options? Should we consider them only in the very advanced phase of Parkinson, when everything else has failed? Or should we consider deep brain stimulation and other advanced therapeutic options as soon as the medication starts not to work properly? And let's take a look at the results. Great, another great discussion I had. I tend to agree with the second statement. So I tend to agree that deep brain stimulation should be considered as soon as we realize that the medication is not working perfectly, because there is no advantage in keep on using a medication that is not the best one, but there is truth in both of that. So Dr. Dolm and Dr. Krishna will tell something to us about this. Let me introduce Dr. Dolm. Dr. Dahlm is an excellent surgeon who completed his neurosurgical residency and fellowship at the University of Iowa. He moved to Houston, Texas, where he worked at the Houston Methodist Hospital, and he served as director of the Pain and Functional Division prior to joining Ohio State University in 2019. And Dr. Dahlm today will talk about deep brain stimulation. After him, we will have Dr. Krishna, who needs no introduction. Dr. Krishna is an expert neurosurgeon scientist at the Ohio State University. He has experience in neuromodulation and functional neurosurgery. Dr. Krishna is deeply involved in research and especially in investigating ultrasound-focused ablation and the use of imaging to improve the outcome of deep brain stimulation. Dr. Krishna has co-developed a technology using what we call tractography, which is a fancy word to say that he looks very, very, very thoroughly into the brain to figure out where is the best spot to deliver deep brain stimulation. And today he will talk to us about focused ultrasound ablation. So let's move forward with the presentation of Dr. Dahlm, followed by the one from Dr. Krishna.
Hello, everybody. Again, thanks for joining us today. Today, my goal is to kind of give you the 10,000-foot overview of surgery for deep brain stimulation therapy. This could be for Parkinson's disease. It could be for other indications that we use it for too, but obviously today's talk is focused on Parkinson's disease. Next slide. So we break up deep brain stimulation into two stages. The stage one is where we actually put the lead in. Sometimes we stage the lead implants by several weeks or several months. But stage one, when we refer to that, that's strictly the lead implant part of the procedure. Stage two is where we hook up the leads to the battery. So there's actually an extension cable that will go down from the leads that are in the head that then connect to a battery, and that's stage two. And typically we'll perform that about 2 weeks after the stage one procedure. Even though everything's connected, we don't actually turn it on at that point. The device is interrogated and turned on and programmed at your initial programming session, which happens about 2 weeks after the stage two. Next slide. So this is a picture of some of the targets that we use for deep brain stimulation. For Parkinson's disease specifically, we use the subthalamic nucleus or the globus pallidus internus. And this picture kind of shows you what that looks like. So the lead, that kind of long line that you see going down towards that yellow structure is the lead going into the subthalamic nucleus. And the GPI, which is another target we can use for Parkinson's disease, is that one of the little red triangles or pink triangles off to the right of it. A couple things you can take from this is one, these are deep structures, so hence the name deep brain stimulation. And also this is fairly kind of true to form as far as the size. So the leads are very small, they're a little over 1 millimeter in size. And these structures that we're targeting are also very small too. So precision and accuracy of placement is very important. And really that's our main goal from surgery, is to make sure that we get this lead properly positioned to avoid side effects. That's one of the things about this as well. Is these structures are small, they're also surrounded by a lot of other small structures that if we stimulate those, we could get side effects that we don't want. We ultimately want to stimulate to reduce the symptoms and then to not get side effect profiles. Next slide. So this is an anatomical slice through a picture of the subthalamic nucleus, which if you look at the bottom center part is the STH. And next slide. So our goal during the surgery is to hit that precisely every time. What I'll talk through for the rest of the presentation is kind of how we go about doing that, walking you through the operation, and some of the steps that we use to make sure that we appropriately put these leads in the right spot for you. Next slide. So the gold standard for DBS lead placement or stereotactic neurosurgery in general is what we call frame-based procedures. And these are two pictures of common frames used in the United States. We here at Ohio State use the picture on the left. It's called the Lexell frame. Basically what these do is these frames, if you can remember back from early on in math with your XYZ graphing capabilities, is these frames have XYZ coordinates on it. And once we put that frame on your head, we can dial in XYZ coordinates that allows those probes, and you can see those probes going down and touching the scalp to get to that exact spot that we've targeted. And then we get to the stage 2 part. I won't really harp on this very much. Really, this is just connecting the ends of the leads to the batteries. And this is a picture of what it would look like in the end. Most people will have one battery on one side. Sometimes if we do one implant and then several months later, several years later, do the other side, you can end up with 2 separate sides. But most of the time what we're doing is we're doing a single side. Next slide. And thank you very much.
I see we have a little bit of delay. So in the meantime that this is fixed for Dr. Krishna, Dr. Dom, I think it was interesting to see how there is this 50-50 preference between sleep and awake. So overall, if you have to say, having the chance of being you, a patient comes to you and says, Dr. Dom, I want to do whatever is the best. What would you recommend?
Yeah, I'd say right now, if you want to recommend the best treatment option based on published data, there's more published data for awake DBS because it's been around longer. More and more what we're seeing now is that outcomes between awake and asleep are largely very similar. So we're getting that, again, that gets to the point of better imaging quality, better just experience and knowing with the every procedure you do has a bit of a learning curve to it. So if we're doing things asleep, if we're doing the MRI scanner, if we're going off based off of ORM imaging to help guide our lead placement, we're going to get better over time. So if you're going to consider sleep DBS, I definitely would go or inquire about a place that does it often so that they have good experience with it. If it's me, I would feel comfortable if I'm at a place that does it frequently to do it asleep. But that's something I would definitely ask if wherever you end up going, ask your surgeons.
I want to say one thing before giving the word to Dr. Krishna. Something that we do here at the Ohio State is a kind of a combination of 2 technologies. So we use the extra level of accuracy done by the intraoperative imaging, but we also do this awake. So we will be able potentially to do this asleep because we have all of the tools to make sure that the lead is placed exactly, but we tend to ask patients to stay awake, so we have this additional layer of safety about the placement. And I think this is probably the best option possible. I got a message that Dr. Krishna's presentation is ready, and then later I anticipate a lively discussion. So I yield to Dr. Krishna and looking forward to his presentation.
Good morning. My name is Dr. Vibhor Krishna. I'm an assistant professor of neurosurgery at the Ohio State University Wexner Medical Center. I welcome you to the 2021 Parkinson Symposium. I want to thank all the participants for being here today, and thank you for sharing your stories and being a part of this dialogue. The challenges that we learn by talking to you inspire us to work hard. Your trust in our care motivates us to improve patient care and set new industry standards. When you feel better, it brings us joy and satisfaction, and that's what we cherish the most. Today I've been tasked to talk about focused ultrasound ablation and how it pertains to the care of patients with Parkinson's disease. We'll talk about 3 main questions. What is focused ultrasound ablation? What to expect during focused ultrasound surgery? And what cutting-edge research we are doing at Ohio State to make surgery safer and more effective. Focused ultrasound harnesses ultrasound technology to undertake targeted ablation in brain areas with abnormal activity. The surgery is done in the MRI suite. As you can see, this is an awake patient inside the MRI, and the helmet on their head is the ultrasound transducer. MRI allows us to do live imaging of the brain and really pinpoint the areas of the brain where the targeted ablation would improve symptoms. Once we have identified the brain area, we increase the ultrasound delivery in small increments. Initially, keeping the energy low allows us to do testing to understand whether undertaking ablation in that area would be safe and effective in reducing patient symptoms. Once we deem the area to be safe, we increase the ultrasound energy further to make the ablation permanent and improve patient symptoms in long term. You can see the results of a treatment after focused ultrasound. Why some patients may prefer focused ultrasound? There are several factors. It's an incision-less surgery. The results are immediate. It doesn't require implantation of hardware and no need for battery replacement. The FDA has approved this treatment for essential tremor and tremor-dominant Parkinson's disease. And currently there are clinical trials that are undergoing to test its safety and effectiveness for the treatment of Parkinson's disease fluctuations and epilepsy. What to expect during focused ultrasound ablation? First step is patient preparation. That involves shaving the head, allowing us to have a coupling between ultrasound transducer and patient's head. In the next step, we place a head frame that allows us to keep the head steady during surgery. As a next step, we do the planning to identify brain areas for ablation using MRI imaging live at the time of surgery. And finally, we increase ultrasound energy in steps, initially for target verification, to do testing and understand whether undertaking ablation will be safe, and then increasing energy to higher levels and achieve a permanent ablation for long-term symptom control. This is an example of a patient we treated at Ohio State, 55-year-old woman who is an artist, developed refractory tremors, which were disabling and did not respond to medications. We assessed her at Ohio State, presented her with options, which included deep brain stimulation and focused ultrasound, and she chose to undergo focused ultrasound ablation. She underwent thalamotomy procedure with good control of her tremor without any side effects. This is an art that she created for us after focused ultrasound surgery, and you can see that her tremor has very good control. We are working at Ohio State to improve the safety and effectiveness of this emerging treatment, and we are using an advanced imaging technique called tractography to achieve better safety and effectiveness. This technique allows us to map out in great detail brain areas that we have to avoid during this ablation and pinpoint the area where the ablation should be focused. And using this technique, we are able to cut down tremor upwards of 50% without any sensory loss or paralysis. We observed gait disturbance in 30% of patients that resolved by 6 months. We are also looking at other methods to understand the tissue response after focused ultrasound surgery and optimize in a way to understand what are the predictors of good outcomes after this treatment. In summary, focused ultrasound is an incision-less treatment that can be done in one session without the need for anesthesia. The tremor reduction we expect is 50 to 70%. There is no need for implanted hardware. There is a low risk of permanent side effects. Important thing to recognize is that symptom control with focused ultrasound is on one side of the body. FDA has approved it for use in one hemisphere of the brain. We are doing clinical trials to assess whether it can be safely done on both brain hemispheres. And long-term symptoms need to be determined since this technology is 5 to 7 years old. Today we discussed 3 important questions. What is focused ultrasound ablation? What to expect during focused ultrasound ablation? And research that we are doing to make this operation safe and more effective. I thank you for your attention.
Excellent. Great presentation. So I think we have a little bit of time for questions and answers. Clarice, do you want to take the lead of the questions?
Absolutely. Let's talk about a few questions regarding deep brain stimulation. Dr. Dom, is DBS only used for the severe motor symptoms of PD?
So DBS is primarily used for the motor symptoms of Parkinson's. It can be for the slowness of the movements. It could be for tremor, kind of like what Dr. Krishna discussed with the focused ultrasound for primarily for tremor with DBS. The primary benefits that you'll see with deep brain stimulation therapy are the benefits that you get with the medications. Oftentimes the stimulation kind of acts as it acts together with the medications to boost their effect. So if there's a component to the Parkinson symptoms that you're not getting improvements with the medication, it's unlikely you'll get improvement of that with the stimulation.
Dr. Krishna, when was the ablation first used? How many ablations are being done nationwide, and how many hospitals are providing the ablation?
Well, first of all, I would like to say that this is an excellent session. I learned a lot. I'm attending this session both as a patient as well as a panelist here. I have with me my father-in-law, Dr. Rauf. I don't know if I can show him here. He's a Parkinson's patient, and so we have learned quite a bit during this session. That's why I recorded the video ahead of time, because I'm a patient right now. And so, so the ablation was first tried in 2005. And for movement disorder surgery, the first testing started around 2012 is when the cases started to be done. It was FDA approved in 2016. And worldwide, we have had upwards of 1,000 ablations so far worldwide. And so this is an upcoming technology, and more cases are being done. At Ohio State, our numbers are close to 70 or 80 ablations currently.
Fabulous. How many other hospitals across the country are doing the focused ultrasound?
So if you talk about academic medical centers, I think we are roughly 10 or 12 academic medical centers. Overall hospitals, I don't know the exact number now, but roughly 20, 25.
Perfect. Dr. Merola, would you use a focused ultrasound on a young patient or an older patient? Why or why not?
That's a great question. So what I want to say is this: focused ultrasound is a great treatment for tremor. So when it comes to essential tremor, where we only have tremor, focused ultrasound is definitely a great treatment. When it comes to Parkinson, we have to be very careful in the selection, because focused ultrasound can be the perfect treatment for a patient who has a lot of tremor. But if there are other symptoms, so it's not only tremor, but there is also slowness of movement, maybe deep brain stimulation can be a better fit. Regarding the age, it's not really a matter of age. I think it's more a matter of how bothersome is the tremor as compared to the other symptoms. Dr. Krishna, would you agree with me?
Yeah, these are the great points, Hari. The idea is, if tremor is your main symptom, then focused ultrasound can be a good option for your symptoms. Parkinson's disease, as Dr. Merola said, is thought to be a combination of symptoms, and we are trying to have improvement on both sides of the body. And so, as I mentioned in my presentation, focused ultrasound right now is only looking at one side. And so overall, when you think about the overall presentation of patient, deep brain stimulation addresses holistically all your symptoms. And so it's overall more comprehensive treatment for your symptoms.
Fabulous. Dr. Chang-Easy, does DBL help to improve gait and balance?
Ooh, okay. So, am I unmuted? That's a mixed question. Yes, it can improve gait for a certain subset of problems with gait. So gait is walking. And if walking impairment is due to stiffness or slowness, those are features that improve with deep brain stimulation. Balance does not improve with deep brain stimulation, and there is a question of it actually worsening slightly. Very common for us to prescribe physical therapy after the deep brain stimulation. I use the analogy of having sea legs, and so getting used to post-DBS, your new body post-implant, oftentimes this gets better with some physical therapy. But balance is not an indication to get DBS. Slowness and stiffness with shuffling walking do improve with DBS, and that will improve the walking.
Thank you. Jared, I have a question. Two questions for you, Jared. One, due to COVID, it's really hard for Parkinson's patients to get some exercise and stay moving. So do you have any tips or tricks for folks to do exercise in the COVID era? Second question leading up to that is, if you had to pick one piece of exercise equipment for Parkinson's patients to have in their home, what would you pick?
Oh, okay. Well, the piece of exercise equipment has to be individualized. Everybody going out and getting a treadmill is not a safe alternative. We can do a couple visits where we find a piece of exercise equipment that is feasible and safe. And so it's very individualized. What was the first question? I'm sorry, Clarice.
What are the options for patients currently due to COVID, exercise options that they can do at home?
Yes, okay, so we need to do, there's some virtual options. So if you go to the National Parkinson's Foundation, they have, they've created a platform for home-based therapy, and you can do it online, just like you're doing this talk today. And so they have some exercises that they're guiding you through a different series over the weeks, and that's available on the website for free, so you can check that out. We are establishing an online platform as well, just for ongoing use, even past COVID. And so we will continue to update that. Delay the Disease. Let's all just be inclusive for exercise. They have an online platform as well. And so you can check that out as well. So there are some options to do at home. And then I can always give you some ideas as well to participate with a caregiver.
Fantastic, thank you.
Can I ask a question? I mean, can Jared talk about the stationary bike or rowing machines? That's something we're commonly telling patients, or what would you advise?
The only thing is, like, so there is also a stepper option. So there are some orthopedic like limitations to a recumbent bike with knee flexion and having enough like flexibility. So sometimes it makes it a little less feasible for going around in a circle, but there are some stepper options if there's some orthopedic limitations. Obviously, hips and low back are a thing to keep in mind as well. Most of the research is best around treadmill walking as early as possible is the most feasible aerobic option. It's not good for everybody's balance. The next best is recumbent biking if we had to kind of put a hierarchy on which piece of exercise equipment has the most support in research.
Thank you. I'm hoping we have time for at least two more questions.
Only one, Clarice.
Oh, one question. Okay. I think this is an important question. Dr. Merola, is the Duopa pump superior to deep brain stimulation?
Oh, this touched me in the heart because I did a study in which I compared the two options. So the answer is they are equivalent. Duopa and deep brain stimulation, they have the same efficacy. But the type of patient who wants to have Duopa is generally different from a patient who wants to have deep brain stimulation. Deep brain stimulation is a little bit more invasive for doing the entire procedure, but then later everything stays inside of the body and there is no maintenance required. Duopa has the same efficacy, but the procedure is way less invasive. It's just a 15 minutes procedure done in very local anesthesia. But then later, the patients we will need to carry a pump and to connect and disconnect. So it's really a matter of discussing what are your priorities. But in terms of efficacy, they have the same efficacy.
Thank you.
This is all the time we had for today. And I would like to recap first saying thank you so much for attending this event. We put this series of events together because we felt like there was a need for communicating scientific information in plain English. This is the first of these events. So please forgive us for little technical difficulties or organization. It will get better with time. We plan to do this on a quarterly basis, and we plan to make available all of the material. We have 60 questions in the Q&A box, and even though Clarice did a great job, we will need to address some of them in a different format. Clarice shared the link that is basically wexnermedical.osu.edu/movement. And I know that at this time, all of the information are not there yet, but within a couple of weeks, we will make sure that everything is there. And we will also make sure that there will be an email address regarding research questions. Also, this is something we're doing together. So any feedback, any willingness to contribute, any willingness to give us feedback from patients' perspective. I read some questions that were excellent about what topics we can discuss, how can we explain this better, what aspects were a little bit, more difficult to understand, or what presentation we can do. This is very meaningful for us. So we really want to work together on this. You will receive a feedback survey. Don't be too harsh on us, but please mention whatever can be done for us to improve. We want to do this 4 times per year. And the next dates will be on April the 10th, July 17th, and October 16th. We will put these available. And the website is moving. And we are changing this in order to make this more accessible. So thanks again for participating today. And thanks to all of the panelists for giving such beautiful lectures. It was really engaging. And we look forward to see you again in April.